Good morning, everyone. I am just getting the meeting starting here, so bear with me for just a second while we get all of this going. Okay. It is 11, so we're going to go ahead and just get started. I think we still have a few people popping in as we move forward, but we will. I think it is allowing people to come in automatically, not have to be admitted, so should be good there. My name's Jennifer Sullivan. I am with Boone Insurance Associates. Boone Insurance Associates is for those of you that don't know, is a life and health insurance broker located here in Eugene, Oregon. However, we do serve the entire state of Oregon. I myself have been an agent here for the last 12 years. I've been with VIA for 12 years. I specialize in Medicare, group, and individual, both on and off the marketplace. And I am going to introduce my lovely sales team who is with me as well. And we'll start with Lainey.
Good morning, everybody. My name is Lainey. My name is Jelaine. My clients will know me as Lainey. I am one of our sales team members here, and I have been with Boone Insurance for 13 years this June. I work both the sales team and the service team over the years. I've done a little bit of everything with the company. I am our only remote sales associate. So to work with me, you would have to be willing to do everything by phone. We could do a Teams meeting, but you have to be able to do online systems, online forums, things like that. But I do specialize in the Medicare, the individual, both on and off market, and I dabble a little bit in group.
Thank you. Daniel?
Yes, hi, my name is Daniel. I've been with Boone Insurance for about 3 years, and I also work in Medicare, individual, both on and off market, as well as small group.
Awesome. Thank you, guys. Well, everyone, welcome. This is our Medicare 101 Medicare Made Simple workshop. This is our first official one, so we appreciate all of you kind of bearing with us as we get our toes in the water and start doing this quarterly. So we will be doing this quarterly going forward. I just want to point out that while I am presenting for the most part today, all three of us are licensed agents that you can work with equally. So we all have a lot of knowledge between the three of us. I'm going to just go over a couple of housekeeping items. As you probably noticed, your cameras and mics are turned off. We're doing that for this one today. Just in previous practice sessions, we have found that sometimes technical difficulties with people's technology can get a little bit troublesome. So we thought this might be the best way to approach it. I want to point out that this is an educational session only. There will be no sales presentation of any kind, no product information of any kind. Anything that you want to know about as far as specific products and plans, pricing, and all of that can be done with one-on-one appointments, and we'll get into that in a little bit. We're going to walk you through how original Medicare works. And then dive into what your options are beyond original Medicare. Whether you're turning 65 soon, already on Medicare, or just trying to understand how it all works, maybe helping a loved one, or you just need a refresher after being on Medicare for a few years. Hopefully this will make it a little less complex for you. This is being recorded, so I do have to let you know that, and we're happy to share the recording afterwards for anyone that wants it. We'll probably have it on our website as well, I imagine. So I think that is everything. We do have a Q&A open and live, so if you have questions as we go through, go ahead and pop them into the Q&A. Daniel and Lainey are going to be answering those as best they can as we move through. We would ask that you keep your questions general. If you have specific questions about your own personal situation, whether it be medications you take or doctors or anything specific to your own personal situation, we would ask that you keep those for an appointment that you can set up directly with an agent. We're just trying to keep, private health information outside of the Q&A today. I also have a chat open. So anything that you would like to share, you can pop into the chat. Starting with, just before we jump in, I just want to know, has everyone already started looking at Medicare options, or is this all brand new? I would love to know kind of where everybody's coming from as far as that goes. If you'd like to pop that into the chat, that would be super helpful. Okay, we're going to go ahead and dive right in. Awesome, brand new, starting to look at options. Thank you for sharing. I love the information. Okay, so it sounds like, yeah, we're just getting started and learning brand new. I think we kind of already talked about Boone Insurance Associates. We'll at the end talk about how you can get a hold of us and how all of that works and what our process looks like at the end. Okay. We are going to start with signing up for Medicare. So anybody that is 65 or older, under 65 who have been declared disabled for 24 months, so that's going to be on Social Security disability for 2 months, 24 months, 2 years, or certain situations with people with end-stage renal disease qualify for Medicare. So the first step before you do anything, and actually this is something that our office doesn't specifically do, so this is something that you kind of have to do on your own, of course, with our guidance, signing up for Original Medicare. Original Medicare consists of 2 parts, just 2 parts, A and B. That's all that Original Medicare consists of. Those 2 parts you have to get directly through Social Security. Part A is automatic. When you turn 65, you're automatically going to be signed up for Part A, and I'm going to talk about what that is. If you are drawing Social Security benefits, you will also automatically be signed up for Part B. But most people are not. They're either turning 65 and delaying Social Security, or they are past 65 and they've been working and they've been delaying Part B. Either way, you'll have to go and sign up for Medicare through Social Security. You can do that on their website at socialsecurity.gov. This is my recommendation if you're comfortable with a web browser. You create a login, you just go in and you fill out the form and answer the questions. We do have a couple of guides we can provide to walk you through that process. Alternatively, you can contact your local Social Security office. I will tell you that I tried to do that yesterday on a personal matter and there was a 90-minute wait. So if you can avoid that, doing it online, I do recommend that. But if you're patient, you can contact them by phone and sign up that way. That's how you get signed up. Okay. All right. We are going to start with just a little bit of overview of basic terminology before we dive in. I think everybody probably is pretty well versed on this, but I'm going to use the term cost share fairly often. Cost share refers to things like deductibles, copay, coinsurance, out-of-pocket maximum. These are going to be price points that you have to cover. Basically, you're sharing in the cost of your care when you use your plan, and that's what we refer to as cost share. A deductible is going to be how much you spend for services before the insurance company will pay. A copay is going to be a flat dollar amount or payment that you make each time you access a service. A coinsurance is just a fancy word for percentage. So if it's not a flat dollar amount that you're paying, it could potentially be like a 20% coinsurance. Out-of-pocket maximum is the most that you have to spend for covered services in 1 year. So just a little bit of an overview on that. All right, we're going to start talking about Original Medicare, which, like I said, consists of 2 parts, Part A and Part B. Part A is what we call our inpatient or hospital coverage. It's going to cover hospital stays, home health services, hospice care, and some skilled nursing facility visits with limits. I kind of like to think of it as any type of sort of inpatient type care when you're talking about, like overnight stays and things like that. There is no premium for Part A. So if you've been working and paying into the system, you've earned Part A, and you do not pay a monthly premium to have Part A. However, there is a lot of cost share associated with using Part A. And people like to say, oh, I heard Part A was free. It is free to have, it's not free to use. So if a person were to only have Part A, let's say you had nothing else, just as an example of a hospital stay in 2026, if you were hospitalized from anywhere between 1 and 60 days, you would have a deductible of $1,736. That would cover the first 60 days in the hospital. If you had a longer hospital stay and you flowed into days 61 through 90, you're flipping over to a daily copay of $434 per day. And if you're in longer, 91 to 150 days, you are going to be at $868 per day. Now, the interesting thing about Part A and this deductible here is that most people consider deductibles to be annual, right? They reset every year. These actually reset every benefit period. Under Part A benefit period is 60 days. So if you went into the hospital for, let's say, 4 days and you paid the $1,736, and then you went back in 10 days later, you'd still be within that benefit period. You'd still be covered. If you go back 90 days later, you're going to start over. So this can reset every 60 days. Skilled nursing facility, you do get 20 days at no cost share. And then days 21 through 100 are going to be a $217 copay per day. After day 100, Medicare does not cover skilled nursing. So this is where a long-term care policy or something like that, you would self-fund those stays. And then, of course, hospice is covered in full. Home health services has some limitations to it. It's a little bit complicated depending on the situation and what type of care you need. Happy to go into that if somebody needs specifics in a one-on-one appointment. That is basically Part A. If anybody has any questions about that, feel free to pop it into the chat. Now, you're probably panicking a little bit because this seems like very high cost. Just be aware that most people don't pay this because they don't just have Part A. We're going to talk about how we cover these costs later on. Part B. Part B is our medical coverage. So this is going to be our outpatient services. These are going to be all of your physician services, doctors and specialists, testing, labs, imaging, x-rays, chemotherapy, ambulatory, emergency room, urgent care, outpatient surgery, whether it's in the hospital or at an outpatient ambulatory services center, preventive care. So obviously your mammograms and colonoscopies and things like that. And then Part B medications, which can be confusing, not to be confused with prescription drugs, okay? Part B medications are medications that are administered to you in an inpatient setting. So if you are getting an IV, or even when you're in the hospital and they give you like the really big ibuprofens, those all fall under the Part B benefit. Prescription drugs, things that you get from a mail order brick and mortar pharmacy, is Part D, which we're going to talk about later. And those are the services that are covered under Part B. Part B does have a premium. So you are going to pay a monthly premium for Part B. The standard premium in 2026 is $202.90 per month. That is going to be income dependent. So as you can see here on this chart, if your annual gross income is more than either 109 for an individual or 218 for a couple, you're going to pay more for Part B. And you can refer to this chart to find out how much you would pay. If you are drawing Social Security, that premium will come right out of your Social Security check, just right off the top. If you are not, you are going to get billed for that premium, and you're going to get a bill for 3 months at a time. If you want to write a check, you're going to have to write a check for 3 months at a time. You can set it up on auto pay to do monthly payments. The only way to do monthly payments is to do auto pay through a checking. For whatever reason, I don't think they want checks from, millions of Americans every month. So they're going to make you do it for 3 months at a time. The way that the services that we just talked about are covered under Part B, the cost share, is actually a lot more simple than Part A. There is just a flat deductible each year. This is an annual deductible of $283. Now that's the 2026 deductible. That does change every year a little bit. Usually goes up. I don't think we've seen it go down. At least I haven't in 12 years. This year it's 283. So when you first start Medicare, you're going to pay the first 283 of any of your Part B services. After that, you're just going to pay a 20% coinsurance. Medicare is going to pay 80%. It's that simple. 80-20 split after a $283 deductible. And that's pretty much how Part B works, right? If you have any questions, again, feel free to pop them into the chat. Now, depending on what kind of coverage you've come from, maybe if you've been with the marketplace or on or off the marketplace on an individual plan, you might think, wow, that's actually a $283 deductible is actually great, and 20% coinsurance isn't bad, right? If you're coming from a $9,200 deductible on the bronze plan through the marketplace. But some things to consider, the biggest differences between those plans and Medicare, and some of the big holes in Medicare. Number one is that, and this isn't even on here, I don't think, there is no prescription drug coverage under A and B. You have to go out and get that yourself. It's called Part D, and we're going to talk about that in a minute, but it is not included. So that is one thing that you have to seek out that they're not going to give you. Another really big one is there's no out-of-pocket maximum on original Medicare. So you don't have that ceiling or that stop loss. If you were, say, doing inpatient chemotherapy, you would just be paying 20% of that with no cap. And that can really get expensive. There's no routine physical under original Medicare. You get what's called a wellness visit, which is not even really a checkup. But you don't get the routine physical where you go in and meet with your doctor and they, check your vitals and take your labs and, your preventive visit. Medicare doesn't cover that. They also don't cover, any of the ancillary things, dental, vision, wellness things like gym memberships, alternative care, chiropractic, and things like that. So all those bells and whistles that you might be getting from your group plan, original Medicare doesn't give you. It's just medically necessary services. All right, that's A and B, what it covers, what it doesn't. I'm going to talk about Part D really quick. I'm going to jump ahead. I apologize. Part D is prescription drug coverage. There are a couple of different ways that you can get that, which I will talk about here in a minute. But Part D is a standardized program through the government. But all the private insurance companies that sell it have their own variations of this program. But it basically will consist, just covering prescription drugs will consist of a deductible phase, and then what's called initial coverage, which is going to be co-pays or co-insurance on your drugs, and then a catastrophic phase that when you hit your out-of-pocket max, you actually do not pay for drugs beyond that price point, which again, I will provide more information on. Part D is mandated. You do have to carry prescription drug coverage. So even if you don't take drugs, it's important to know that you do have to have Part D. And we'll talk about how to get it. So we're going to dive into what our options are beyond original Medicare. Now that we've laid down this foundation, and this is sort of pinned here to the top, we have to have A and B, and we have to pay that Part B premium no matter what we do. But we do have two different paths that we can go down now that we've laid that foundation, or two different houses that we can build on that foundation. I'm going to start with the Medicare supplement plans. These are also referred to as Medigap plans. Okay. These came first. These were the original style plans back when Medicare first started. They work together with Medicare, sort of like secondary payer. Primary and secondary payer, kind of like that, how that works. What happens is you would have a supplement and your Medicare would kick in first and pay your provider, and then your supplement would come in afterwards and pick up varying levels of the remaining cost. These plans are standardized by the Center for Medicare and Medicaid Services, meaning that they are the same plans no matter what company you buy them from. And this can get a little complicated. There are roughly 6 to 8 supplements, correct me if I'm wrong, team, but there are about 6 to 8 supplements labeled Plan A through Plan N. Not every letter is represented because that would be more than 8, but there are about 6 to 8 of these plans. And those 6 to 8 plans are the exact same, whether you buy them from whoever, company X or company Z or whatever. I guess I can use names, United Healthcare or Providence or Humana or whoever you buy it from. The plans, the Medigap plans are the same. I should also point out, because I forgot, that Medigap is another word for Medicare supplement. So I apologize if that got confusing. Supplements, Medigap plans are the same thing. Those two terms are synonymous. So Medigaps are standardized, meaning that they are the same plans no matter who you buy them from, but every company charges different rates, right? Kind of like buying a standard liability auto insurance plan from State Farm versus Geico versus Progressive. You got the same insurance, same plan, different pricing. So you can shop around and we help you figure out who has the best rates. So going back to our little chart here, these plans work together with Medicare, like I mentioned. Depending on the plan that you have, it will pick up some or all of the remaining cost after Medicare. So you go to your doctor or your specialist or whoever, you have your visit. The bill goes from that provider's office to Medicare. Medicare pays their portion. The bill goes to your supplement company. And depending on what supplement you have, it will pick up some or all of the rest of the cost. So basically filling in cost gaps, hence the name Medigap. What's important to know though, is that it doesn't fill in any benefit gaps. So it does cover the cost gaps, doesn't cover the benefit gaps, meaning if A and B doesn't cover something, Medigap plans don't either. So it's not providing any additional coverage, it's just providing cost share coverage. So biggest issue with that is prescription drugs, right? A and B doesn't provide it, therefore the supplement doesn't provide it. So that's why there's 2 boxes on this side. If you have a supplement plan, you also have to obtain a standalone Part D prescription drug plan. Again, this is something that we help you with. You do have to have this whether you take drugs or not. So now you've got your supplement, you've got your prescription drug plan, 2 different companies most likely. And then if you want dental, you have to buy that separate. If you want vision, you buy that separate. Or you can self-fund those things. But if you want all of those different things, you're essentially buying all these different plans, piecing them together to form your total healthcare package on this side. A couple of things to know about supplements. First one of the biggest ones is there are no networks under Medicare supplements, which is one of the I don't want to use the word advantage because that'll get real confusing, but one of the perks of a supplement is that they don't have any networks. So you're not going to see these acronyms like PPO and HMO and all this other, in or out of network. If a provider anywhere in the United States takes Medicare, the supplement will pay. So if you seek services in Oregon and then you have a home in Arizona and you have a doctor here and you have a doctor there, your plan will work exactly the same here as it does there, and New York and anywhere else in the United States. So it works great for snowbirds or, anybody that really needs to be able to seek, especially primary care outside of Oregon. So that's an important piece. One other pretty big piece and important piece, which can be a little bit hard to understand sometimes, but Medicare supplements are actually what we call underwritten products. An underwritten product means that in order to get a supplement, you actually have to go through medical underwriting and get approved. Medical underwriting is a process by which you might answer a bunch of health questions and see if, they're willing to take you on as a member based on, the risk that they might incur based on your health. So in order to get a supplement in most cases, you do have to go through that underwriting process. However, when you first go on Medicare, when you first pick up Part B, you do have a 6-month guaranteed issue window. Guaranteed issue means you are guaranteed to be issued a plan. No underwriting. So you have a 6-month window, guaranteed issue to pick up a supplement without having your health assessed. No pre-existing condition clauses. You're guaranteed to be issued the plan. as long as you have A and B and you got B within the last 6 months. If you decide not to do a supplement and you wait beyond that 6-month period, in order to come back to or come over to a supplement, you would have to go through that underwriting process. There are some exceptions to that, and we're happy to go over those in one-on-one sessions or private conversations based on somebody's specific situation. But there are some exceptions to that and some nuances to that just to keep in mind. Let's see. I'm gonna jump in here and just refer to my team. Did I miss anything important on the supplement side that you can think of? Okay, I think I'm getting head nods that we're good.
Not that I can think of. I think you did a great job covering it.
Okay, excellent. I do see that there are some questions in the chat. If you guys don't mind putting the questions in the Q&A, and totally fine, we can do it either way, but we would prefer to have the questions in the Q&A so that everybody can see the questions and the answers, and then we can make sure we address all of them. Okay, well, we're going to close the book on supplements for now, or actually just put a pin in it, and we can come back if we need to, but we're going to jump over to what we call Medicare Advantage plans. So completely different type of plan. Everybody uses the word supplement in this when they're new to this, and it just refers to this. If you have an Advantage plan, you do not have a supplement. So Advantage plans are actually kind of the opposite of a supplement. They do not work together with A and B. They actually replace A and B. Okay, so you still have to pay for B, right? That, like I said in the beginning, that's pinned up here. You do not get out of that. But the Advantage plan is now coming in and taking over all of the administration of your health plan, paying the claims and doing all the administration. Medicare A and B is actually paying your Advantage company some money from your Part B premium to the Advantage company to deal with you. So they're basically saying, here's some money, you deal with Jenny, we're out of here, right? You deal with it. The Advantage plan takes over. Advantage plans include all of the Part A services and all of the Part B services, and most often, in most cases, include Part D prescription drug coverage as well, rolled right in. And then most of them, I think all of them at this point right now, include some dental, some vision, and a gym membership. And then there are some that take it even further and throw in extra things like chiropractic, acupuncture, naturopath, over-the-counter credit to buy your vitamins, and a whole slew of other potential bells and whistles, so to speak, all rolled up into one plan, okay? These plans do use provider networks, so this is where it can get a little bit tricky, but there are going to be different types of Advantage plans, and you're going to hear these little acronyms like HMO and PPO, and I will go over what those mean. But basically, your Advantage plans have networks, which means they contract with groups of doctors. They negotiate a contract, they form a contract, and you have to work within that network. If you choose to have what's called a PPO or preferred provider organization, this is where they have created a network of doctors that are considered preferred providers. And if you see one of those providers, you get the better cost share, the lower copays. But you are able to go outside of that network to non-preferred providers, and you still have coverage. You're just going to pay a higher cost share. Those are PPOs. Now, I will tell you, in the last, 18 months, things have gotten a little more complex with the PPO model, and this is not something we've worked into the 101 yet, but it's coming. Gone are the days of being able to have a PPO and see whoever you want. I don't know if any of you have had experience with this lately. Maybe some of you have. Most of the time, places like Oregon Medical Group, Praxis, they won't bill out of network. So even if you have a PPO, you might not be able to seek services from those providers unless you're willing to pay full price, if they'll even let you do that, and then go back to your insurance company to get reimbursed. So the PPO model is becoming a little bit tricky. We've put out some articles and some information in our latest newsletters. More to come on that. If you would like to get added to our newsletter distribution, send us an email and let us know. I'll give you our contact information, and maybe one of you can just pop it into the chat right now, and take note that we will be delivering more information on this because it is becoming more and more problematic, especially here in Lane County. So technically that's a PPO. An HMO is a health maintenance organization. This is going to be a closed network. So you have one tier of coverage, one level of cost share. You have to stay within that network. So as long as the providers that you see are in that network, you're good to go. If you wanted to seek services from somebody outside of the network, you would not have coverage unless it's an emergency. So you still have urgent and emergent coverage anywhere in the United States, but it's limited to, an emergency room visit. So that's just something to keep in mind. HMOs are becoming more and more popular. These are going to be your lower cost, better plan designs. It's just the way that things are going right now, unfortunately. Okay, so back to our little chart here. Medicare Advantage plans. They work together with Medicare. They use provider networks. There's different types of provider networks. They wrap everything under A, everything under B, add in prescription drugs for the most part, and then a variety of other things. These plans are cost sharing plans. So this is where all of those cost share terms come in. Unlike the supplements where you pay a high premium and little to no cost share when you use the plan, the Advantage plan is the opposite. You pay little to no premium, but you pay cost share every time you use it. So every service you seek is going to have a copay. Sometimes that copay is zero, like primary doctor visits are often zero. But everything else, you're going to have a flat dollar copay. And then in some cases, things like durable medical equipment, chemotherapy, those are going to have a 20% coinsurance. So on an Advantage plan, you are paying every time you use it by way of cost share. Now they do provide that out-of-pocket maximum, that limit. So you're not going to, be faced with, thousands or tens of thousands of dollars in costs. The average out-of-pocket maximum this year, I want to say, is probably right around what, you guys, 55 to 6,000, somewhere in there. Some are a little higher, some are a little lower. That's about the average, right around 5,500 to 6,000. So what that means is that if you had a really, really hard, tough year health-wise, and you were, spending a lot of money in out-of-pocket costs, if you hit that 55 or 6,000, the plan would pay the rest after that at 100%. Now this is the Part D portion is separate. The Part D portion, drugs have their own out-of-pocket maximum, which I will get into. So this is just going to be your A and B services. So Advantage plans, they are never underwritten. They're always guaranteed issue. So when you first go on Medicare, you can pick one up, any one you want, and you can change it every year during the open enrollment period, which Lainey's going to go over in a little bit. Open enrollment happens every year, and you can shop, you can pick a plan. The plan starts January 1st, and you can do that every year. Doesn't matter what your health situation is. They don't look at any of that. I think that might be everything that I have on Advantage. What do you guys think? Miss anything?
And you're going to go into the prescription drugs a little deeper separately, correct?
Yes.
Okay.
All right. Let's go into Part D. So whether you are obtaining Part D on a standalone basis through an insurance company to kind of go alongside your supplement, or whether it's built into your Advantage plan, it's going to sort of operate under the same structure. Okay. In 2026, the standard Part D deductible is $615. That means that you have to meet that deductible before the plan's going to come in and pay. After that, your deductible is met, you're going to go into the initial coverage phase. That's going to be varying levels of copays or coinsurance. Each plan's going to be a little different there. Okay. And then the catastrophic coverage kicks in after you have spent $2,100. If you've spent $2,100, then your cost share goes to zero. You don't spend anything on drugs after that. It's important to know that on most plans, not all, but most, I would say 99% of them, this deductible is waived for drugs that are on tiers 1 and 2. So I don't know if we have the tiers. There are 5 tiers of prescription drug coverage, roughly. Tier 1 is going to be what you call preferred generics. Those are your really low cost maintenance drugs like atorvastatin and levothyroxine and things like that. Tier 2 is your non-preferred generics. It's just kind of a step up, some a little bit higher cost generics. Tier 3 is going to be your preferred name brands. So those are name brand drugs, but the insurance company has them on a preferred list. Maybe they have some sort of deal with the manufacturer. Tier 4 is going to be non-preferred name brand drugs. And tier 5 is what we call specialty drugs. So these are your very high cost, usually like outpatient chemotherapy drugs and things like that. The higher the tier that your drug is on, the more you're going to pay. So if your drug's on a tier 1, you could pay $0 or $3. If you're on a tier 5, you're looking at probably 25% coinsurance, okay? The deductible is usually waived for tiers 1 and 2 drugs, meaning you do not have to meet that $615 before tier 1 and 2 drugs are covered. You're just going to go straight to your copays. And a lot of people just operate in those 2 tiers all year long and never have to pay this deductible. But if you end up with a tier 3, 4, or 5 drug, you're going to meet the deductible first before the copays kick in. Now, because this is the standard deductible under Medicare, it means that that's the most that an insurance company can make their deductible. It could be less than this. So some companies have a lower, some plans, I should say, have a lower prescription drug deductible. So they're not all at $615. Some are lower. Just to reiterate, it can come either in your Advantage plan built in or as a standalone product alongside your supplement. Oh, late enrollment penalties. So like I mentioned before, you are required to carry Part D, even if you don't take drugs. If you don't enroll in Part D, when you first go on Medicare and you have a continuous period of 63 days or more without drug coverage, you're going to pay a penalty when you do pick it up. The penalty is calculated by multiplying 1% of the national base beneficiary premium, which is $38.99 in 2026, times the number of full uncovered months that you were eligible. So if you went an entire year without drug coverage, you would pay 12% of $38.99 in addition to whatever that premium is for that drug plan. This is really complicated. So if you're in this situation or you have questions about this, we're happy to help you calculate what your penalty would be. If you have credible prescription drug coverage like through the VA or TRICARE, you are not required to pick up Part D. That's why there are, when I mentioned Advantage plans, how most of them have drugs built in, but not all. There are some Advantage plans that don't include drug coverage that are specifically for people that are obtaining their drug coverage through another credible source, like certain retirement plans and the VA, things like that, and government-sponsored programs. I think that is everything under D that we need to know. So that sort of wraps up the Advantage side of things. I'll just pause for a second and see if we have any questions about any of that. I know it's probably a lot. So I'll open it up to questions for just a second while I sort of get my bearings here.
And I just wanted to step in to reiterate just something that some people overlook sometimes is that the drugs deductible, the 2100, is only applicable to drugs that are covered. So if the drug is not a covered drug and you're spending out of pocket for that, it's not going to be applied to the deductible, and there's potentially no limit to how much you can spend on that. So just as a heads up, because sometimes people don't know that.
Yes, thank you for that, actually, Daniel. And that also reminded me of something else that isn't in the slideshow yet, which will be added because it's pretty complex as well. There is a new program called M3P that allows you to make monthly payments on your drug costs if you have really, really high drug costs. So let's say you have a tier 5 drug and you're going to hit your $2,100 right out of the gates, day one. There are ways a way by which you can divide that up into a 12-month program and make monthly payments. That is going to be a program that you're going to apply for through your pharmacy alongside your drug plan. And something that we can talk to you more about as well if it's something you need more information on. But that is available, and that's new. Is that new in 2025 or 2026? I think 2025 it started. So if you do face really high drug costs, there are some options for you there.
Mm-hmm.
I'm just going to touch really briefly on employer-sponsored retiree plans. So I know there's probably a lot of people that are going to continue to work, right? And they're wondering, do I need to pick up Medicare? We get a lot of those calls. I turned 65, but I'm still working and I'm on a group plan, and so is my spouse. So I don't really want to come off of this group plan. They pay, 100% or 80% of the premium. I don't really want to go on Medicare and pay Part B when I don't need to. If you are on a group plan that has what's called credible drug coverage, which means that the drug coverage is as good or better than Medicare, you can waive Part B. You don't have to go on Medicare. As long as you or your spouse are actively working, so you have to be working, it can't be COBRA or PERS. I guess PERS has their own plans, but if one of you is actively working and you're covered under that plan, you can waive Part B. You do not have to go on to Medicare. You can push it off until you're ready to retire and come off the group plan, at which time you would then pick up Part B. And the process is a little bit different for applying for Part B in that scenario. There's an extra form that has to be filled out. Again, that's things that we help with. It's kind of important to discern whether you have what's called a large group plan or a small group plan in this scenario. If your employer has more than 20 employees, you're considered a large group plan, then that plan pays primary over Medicare. And we would generally recommend that you stay on your group plan if they're covering a lot of the costs and it's working well for you. If you're on a small group plan, 20 employees or less, it gets a little more tricky, and we might want to meet and discuss that, because in that scenario, even if you don't pick up Part B, Medicare pays primary, and a lot of times they won't coordinate and it just becomes messy. So a little bit in the weeds there, but if those are things you need more information on, again, let us know. We can go into your personal situation on that. But it's just the main thing to know is that if you are actively working and you don't want to go on Medicare, you don't need to go on Medicare, you have credible drug coverage, which most large group plans are, unless it's an HSA, and then you would really want us to check. You can stay on your group plan. You do not have to pick up Medicare. A lot of people hear from their friends and family, well, I heard there's a penalty. I heard there's a penalty if I don't pick up Medicare. There is a penalty if you don't pick up Medicare once you are no longer actively working and on a group plan. And I think that penalty, if you guys, do we have that penalty somewhere? I want to say it's 10% of your Social Security. Correct me if I'm wrong. I thought I had it in here somewhere. But I believe it's 10% of your Social Security that you would get dinged for not picking up Medicare once you're no longer actively working, or if you've turned 65 and you don't have group coverage through a spouse or yourself. Make sense so far, buddy? Did that actually answer your question, Tom? Hopefully. Okay, good. All right.
Jen, we do have a question about PFFS plans. It's just general asking, did we talk about that? And we do have a little blurb about that in the slides. So I thought maybe you could go over that.
Yeah, let me go back to that section. I apologize here. I'm getting a little lost in my slideshow. I tend to, yes. PFF plans, there really aren't, I don't know that there are any of these left available in Oregon. So if you live outside of Oregon, you might have options here. These are work a little differently. It's fee for service, so there's no network. It works a lot like original Medicare and like point of service plans where providers have to be willing to accept the plan's terms. So there's no networks. The providers just have to be willing to accept the plan's terms that are similar to Medicare, and then you pay at point of service. So it's a little complicated. We can probably go into that in a one-on-one. Again, they're not available in Oregon, so we actually don't have any that we sell right now to use as an example. So it's not something that we have a lot of information on right now. What else? Slides available after the webinar. Yes, this is being recorded. So this will be available. The slides are also available on our website. We're also happy to send it to you via email, print you a copy, whatever works best for you. Okay, I'm going to go quickly over just some options for low income. I won't go too much into this, but if you are under certain income limits, there are options for extra help. There's what's called a low income subsidy. There's also what's called being dual eligible for Medicare and Medicaid both. The cutoff as far as combined savings and assets in 2026 is 34,960 if you're married, 17,630 if you're not married. If your income is under those limits, you might qualify for low income subsidy and extra help. These programs will reduce or eliminate your Part D premiums, deductibles, and copays for certain drugs. And then as far as Medicaid, if you qualify for certain levels of Medicaid, some of those will pick up your Part B premium. There are also what's called dual special needs advantage plans that you can pair with your Oregon Health Plan or your Medicaid plan. They work together to eliminate some of your cost share or all of your cost share. Again, if this is something that you need more information on, we can go into that as well. That is pretty much the basics in terms of A and B and D and supplements and advantage plans. I am going to now turn over to Lainey to kind of go over some timeframes.
Yay! Okay, so enrollment periods, timeframes. This one's actually pretty critical. It's without fail. I will receive phone calls from somebody, let's say on March 20th, saying, "Yeah, I need to pick a Medicare plan. I'm starting my Medicare on April 1st." We schedule the appointment, we get into it, and they have not applied for their Part B in benefits yet. And as Jen said, Part B is a requirement. You cannot apply for either a Medigap plan or a Medicare Advantage plan until your Medicare Part B isn't just applied for. It's not enough to just submit your application for it. You have to give Medicare time to process that application as well, which in experience can take 60 days or more. So if your 65th birthday is coming up, please reach out and give us a call at minimum 3 months prior to, so we can get you on the right time frame for that. That said, our enrollment periods, the first one, the most common one, turning 65. Your time frame to enroll for Medicare Part B is going to be 3 months before, the month of, and 3 months after your 65th birthday. So it's a good long period of time. But keep in mind, if you wait until it's the month after you turn 65, 2 months after you turn 65, you may find yourself in a situation where you're uninsured in the meantime. So again, we always recommend at minimum, give us a call 3 months prior to turning 65 so we can start this process with you and be on a good time frame for getting everything finalized in time. We have the annual enrollment period, or AEP as we call it. This happens every year from October 15th to December 7th. This is a time frame in which, if you are already enrolled onto a Medicare Advantage plan, you can switch to a different Advantage plan. If you are on a Medigap plan, you can switch to a Medicare Advantage plan. You can switch from one drug plan to a different drug plan. Basically, all avenues of plan changes are open to you during this time frame. Also, if you are somebody who has found themselves that you are sitting on Medicare Part A and B only, and you've never picked up any of these plans, this is when you can now newly enroll into a Medicare Advantage plan. The Medigap plans at that point for you most likely are still going to be underwritten, which we'll go into that. We would go into the details behind that with you for use personally and specifically if that's a match for you or not during a one-on-one appointment. Next is the Medicare Advantage disenrollment period, also now known as the open enrollment period. It's very similar to the AEP, but it's a little bit different in that, one, it does allow you to disenroll or leave a Medicare Advantage plan and pick up a standalone drug plan instead. Then what you would do is apply for a Medigap plan. It may be through underwriting. It may be under guarantee issue. Everybody's situations are different. But the other thing that open enrollment allows you to do is very similar to AEP. If you are already on an Advantage plan, you can switch to a different Advantage plan. What makes the open enrollment period different in that aspect from the annual enrollment period is during annual enrollment period, you might have an appointment with us on October 15th, and we recommend that you enroll into XYZ plan. You submit an application for it, and by November 1st, we've gotten the word back that, yep, your plan is set to be effective January 1st. And then November 15th, you get a letter from your primary care doctor that they are no longer going to be in network with the plan that you just enrolled into. This is happening a lot. In the last, I would say 6 months, we're getting this a lot. You still have an opportunity to submit another application for another choice. You can submit as many applications as you want during the annual enrollment period, but during open enrollment period, you get one time. So once we submit an application for a plan change from January 1st through the open enrollment period is January 1st through March 31st. That's your one-time option. That period now closes for you. No matter where we are in those dates, that period is now closed for you. The disenrollment period ends on February 14th. It's all in the same time frame, two different things. Disenrollment period to leave a Medicare Advantage plan, pick up a standalone drug plan and a Medigap plan. You have from January 1st to February 14th. Medicare open enrollment is January 1st through March 31st. You can switch from one Medigap or Medicare Advantage plan, to a different Medicare Advantage plan. Special enrollment periods can happen throughout the year, but it's under a qualifying event. The most common one is leaving employer coverage. That's going to give you a special enrollment period to pick up your Medicare Part B coverage, to pick up a Medicare Advantage plan or a Medigap plan. If it's your first time doing so, it would be guarantee issue for you on that Medigap plan. Other special enrollment periods that may occur is if you move outside of your current plan's service area. So it comes up where we have somebody that currently lives in Deschutes County and they move over to Lane County. The Medicare Advantage plan that they were on in Deschutes County isn't available in Lane County, so they are given an opportunity to select a different plan. When that occurs, you have a new guarantee issue right on Medigap plans. Okay, so if you've been on Advantage plan, maybe did we talk about that too, Jen? And when you were speaking about the guarantee issue rights and when they are available and not available?
No, I deferred it to you in this moment.
So when you're turning 65, your initial enrollment period, and you're being faced with choice A being a Medicare Advantage plan, choice B being a Medigap plan, your guarantee issue, no matter which one you pick, they're going to award you the coverage. They cannot deny you for pre-existing conditions. They can't charge you more because of pre-existing conditions or medical history. However, once you have been enrolled onto a Medicare Advantage plan for 12 months, or 12 months in a day, essentially, you no longer have that guarantee issue right to the Medigap options. This is where you would have to apply for it through underwriting. And based on your answers to the medical questions that are being asked, the carrier does have the right to deny you the coverage based on those pre-existing conditions. But in that scenario, you're on a Medicare Advantage plan in Deschutes County, and you've been on that Medicare Advantage plan for the last 20 years. You move to Lane County, you now have guarantee issue right to a Medigap plan again, because you're losing your coverage based on moving. It's open to you again at that point. The last little bit here is the Medigap. We call it the birthday rule. A lot of people know about this, but it's still a little bit confusing. Not every state allows this. This is not something that is pushed down from federal Medicare, meaning the states can choose to adopt it or they can choose to not adopt it. The state of Oregon has chosen to adopt this Medicare or Medigap birthday rule. This applies to Medigap plans only, not Medicare Advantage, not prescription drug. It's Medigap plans only. It allows you one opportunity per year to switch from this Medigap plan to this Medigap plan. That could be all you're doing. You're staying on the same plan, but you're switching which carrier it's with because this carrier is offering it for a lower premium. That's the most common one. In other cases, you may switch from this plan to this plan, which is a downgrade because this plan is cheaper. They do not allow you to upgrade your coverage during this time frame. Okay, that time frame is 30 days before to 30 days after your birthday. That is the smallest window that is available to you. Some of the carriers have the option to expand that window, such as Regions Blue Cross. I think United Healthcare also does the month before, the month of, and the month after. But the smallest opportunity is 30 days before to 30 days after your birthday, and we can help you switch from this plan to that plan, Medigap to Medigap.
Awesome. Thank
Okay.
you. Yes, we only have 2 minutes left, so
Oh my
we we just wanted to, Lainey, if you want to just kind of go through a little bit through next steps.
Yep, kind of covered a little bit of this. 90 days, contact us 30 days prior to your enrollment into Medicare, whether it's over 65 and you're leaving employer coverage or you're turning 65. Call us at least 90 days ahead of time so that we can get you on that right path, okay? We will set up an appointment with you. We will send you an online form to get started. We need to gather information from you in order for us to best assist you. That's an online form that we're going to send out to you. Have things available like your Medicare ID card if you already have it. In certain circumstances, income information if you have it, your current insurance coverage. Know who your providers are. Know what medications you take. These are all the critical components for us to help you in the best possible way. And then we go over the benefits with you. We make a professional recommendation, which one we think you should be on, and then we can assist with that enrollment.
Awesome. All right. Daniel, just want to go over how to get in touch with us and move forward.
Yes, absolutely. So basically, we have our phone number, 541-345-3707. If you're new to us, you would in the menu, you would choose that you're new to us. You can visit our website to submit information. You can also email us at the salesisa@booneinsuranceassociates.com. And then you can schedule an appointment with any one of us. Just as a reminder, Lainey does work remotely, so you'll have to be comfortable with using computers and doing things over the phone. But if you want an in-person appointment, both Jennifer and I work locally here in Eugene, and we're happy to schedule anything. And if you have any questions regarding this seminar, that we weren't able to get to, or maybe just more clarification on, feel free to give us a call or email us, and we'll be happy to answer your questions on that.
Yes, thank you. Perfect. All right, that is basically it for today. Hopefully this gives you a little bit of a clearer picture of how Medicare works and simplifies it. It usually takes, one education session like this and then sometimes additional conversations as well to really grasp it. We really appreciate you joining us today. We are a free service, so if you would like our help, we're happy to help. And we will be doing these quarterly. And if you, again, want any more information, want to be added to a list, go ahead and send us an email or give us a call. Thank you, everyone.